Welcome. I swear I'm not eating cookies. They're delicious. Actually, I planted that. I had a cookie and I was chewing it just so everyone online felt bad that they were not in the room eating delicious cookies with us. But welcome everyone to our High IQ Forum, the Healthcare Institute for Innovation and Quality. My name's Stacy Farr. I'm one of the co-directors of the Institute, and I'm very, very excited for this session. So thank you everyone to everyone who is here. Oh, let me click this OK button. Okay. Oh, okay. Sorry about that. So to kind of kick off today's session, I want to start by really just thanking all of our valued partners. We have BioNexus KC, UMKC, the Health Forward Foundation, and Frontiers Clinical and Translational Science Institute. So thank you to all of our partners who support areas of our work and all that we do. And I want to give just a tiny bit of background for those of you who aren't as familiar with the Institute or its background or, what we do. But, Kansas City really has, the vision of the Healthcare Institute for Innovations and Quality is really that Kansas City will deliver the highest value, most equitable healthcare in the nation. And our mission is really to catalyze and facilitate multi-stakeholder collaborations to improve the quality, value, and equity of healthcare in Kansas City. And, we really have kind of three key aims where what we're really trying to do through the body of work that we do is reduce costs for all of the healthcare stakeholders involved, including patients, payers, providers, and other healthcare leaders. Also improving the quality of care and experience for patients and providers, and creating greater equity in healthcare delivery for all of those in Kansas City. And I want to move rapidly because we have such a great agenda today. But here I want to just share with you our 2024, the remaining of 2024, the IQ Forum agenda. And you can see today we're getting down there. We're at August. And then also do check your inboxes from, I think it was this Monday. There was an email with asking everyone to kind of vote for some of the topics that will be coming up for our 2025 IQ Forum series. So we'd love to get all of your input so we can form the agenda for next year. And I just want to share this graphic. I know it's a little busy, but this is just a little bit of background on the Institute. When we first formed and we're really trying to decide what our regional projects were going to be that we first tackled in terms of this regional quality improvement, where we're helping implement evidence into healthcare and measure the outcomes. So, we started with, and I don't need to go through all this methodologically because there's a lot of other speakers, but, we had an iterative process, including interviews with healthcare stakeholders and leaders. We had surveys, conversations, and voting at our IQ forums, which were also known as the Collaborate to Cure sessions then. And then we also did some nominal group technique work with our advisory board and at the forums to really narrow down what were the most actionable and important and, I guess, priority topics, healthcare topics and issues in our region. And two of those that we landed on were transitions of care for heart failure and then opioid management. So we have this wonderful collaboration with the Missouri Hospital Association on the Western region of engaging patients in care coordination. And so today is really hearing from the group in terms of these updates on this project, where it's at, and where we're going next. So with that, I will now turn it over to, it looks like, to the community perspective, on EPIC from, which is, a presentation with Kristen Feeback and Jennifer Wolf, both of ComCare and EPIC. So I'll switch out
here, so y'all have me.
We're happy to have you. Now let me pull these slides. Let's see which ones look like
The
yours.
second one.
This one? Okay. All right.
Thank you.
Yeah.
Thank you, everybody. So I'm Jennifer Wolf. It's got Brown on the end of it now because I think I've gotten married since that was updated. So it's Brown. Yeah, that's me. So I am the EPIC Western Region Program Director. I started as a recovery coach with EPIC in 2020, and I've just kind of stuck with it because I love it and I love the work that we're doing. And now I'm the director over the program. So I'm going to share with you a little about EPIC here in the Western region. So basically it's to increase access to treatment for opiate stimulant and alcohol use disorders. We started initially addressing overdoses only that they had gone to the hospital for. And we figured out quickly that we needed to get ahead of it, kind of catch them before they get to the hospital. So we expanded to anyone that was having struggles with opiates. And following our NACHO grant that we did a few years back, we expanded even further to include alcohol and stimulant use disorders. So individuals can get a professional referral, or they can call in themselves to our 24/7 hotline. So the mission is to provide 24/7, 365 referral and linkage to services for patients in targeted regions who present to a hospital for opiate, stimulant, and or alcohol use, to establish immediate connections to recovery support services, substance use treatment, medication-assisted treatment services. There's a whole lot more that the EPIC recovery coaches do outside of this, and connecting people to the things that they need. Our motto is, if there's a barrier, we're going to help you hop it, and get them on a path of recovery, whatever that looks like for them. So for the statewide catchment areas, we're the blue region here. We serve 4 counties: Jackson, Ray, Clay, and Platte counties. So anyone within those regions, we can serve them. The lady in the picture who just walked in, she is our North of the River coach. She just started recently. So she handles all those. And then the other 4 coaches that we have right now handle South of the River. Since the inception of EPIC in the Eastern region in 2016, we've served over 20,000 people in Missouri through the EPIC program. Our funding is through Department of Mental Health, Department of Health and Human Services, and SAMHSA. Great folks, y'all. And so what does an EPIC peer recovery coach do? So like I said, we're going to address barriers. So we're equipped to assist with obtaining MAT, temporary housing, job necessities, and transportation to appointments and life needs. Making community partnerships is a huge part of the role that we play, because the more that people get familiar with our program, the more they value the things that we're saying, and value the opinions, because we all have lived experience, so we can relate in that aspect to the people that we're serving. And then we'll journey with them. Let me move this out of the way. Journey through recovery. So we'll assist peers through their recovery journey by providing direct support and advocacy, motivating and encouraging them by using their individual lived experience. I know for me personally, walking through the door the very first time was like the scariest step that I had to make. And so when you have someone who's done it previously, they're with you and can help you navigate that, it's a huge motivation for people. Connection to treatment. So we're going to help with locating resources for harm reduction, detox treatment, local or online support groups, and create recovery plans with them. We do a lot of overdose education, naloxone, and other approved overdose reversal medication. So we're going to give them the education they need for overdose. And we have nasal spray Narcan, and we have injectable Narcan here at our local location. We're also doing the expert and referral to treatment care model. Is everybody in here familiar? Expert, okay. So they typically, when they go into the hospital, they're going to get the substance use disorder screening. The hospital will then make a referral to EPIC if they agree to it. They'll get overdose education and the antagonist distribution, MAT if appropriate. Then there will be a warm handoff to the EPIC coach, and then the connection to whatever treatment services the individual is looking for. So what can EPIC do for patients? So despite anyone's ability to pay, we do provide low or no cost resources like scheduling appointments. And then we work closely with the emergency room enhancement. The program is set up to be with an individual for a year. To be honest with you, that year can be spread out over 5 years. And that's just how it works. But we're never going to say tell someone your year is up, it's over. Like, we're going to figure out how to continue working with them. Okay. Okay, So the target population in the Western region, so this actually, I apologize, that's not been updated. Right now, we're doing 18 and over. And then we're doing Jackson, Ray, Clay, and Platte counties. And it's for anyone who's experiencing any negative health issues and well-being due to alcohol, opiates, and stimulants. So how to refer, and I'll tell you, a referral takes all of 5 minutes from the time that you dial the number. So you make sure the patient's awake and coherent, get their verbal consent to make the referral. Anybody can make the referral except for family members. We don't take referrals from family members, but a professional referral, the individual can call the referral in themselves. And interestingly enough, our self-referrals are higher than any other referral source. And I can just tell you from my own personal experience, many times at 2 o'clock in the morning, I'm like, why am I still doing this? When is this gonna stop? And that would have been the time I would have picked the phone up and made a phone call to somebody. So, and our hotline is right here, 816-412-9417. And the referring person will provide the name of your agency, the person's name, phone number, or email, and then the patient's demographic information, if they have an address, their birthday, phone number, if they have one. And then you give the reason for the referral. They came in for an overdose, or they want to peer, whatever, because we know you're busy, people are busy, and we need to get the information that we need to make contact, and you can, continue doing what you need to do without taking up a lot of your time. And then we'll also need to just make sure they're medically stable and there's no safety concerns. And then if you have any other information, you can share it then or whenever the coach calls back. So the next step is the EPIC coach is going to respond to any referrals within 60 minutes. It doesn't matter if it's 2 o'clock in the afternoon or 2 o'clock in the morning, within an hour, that coach is going to respond to that referral. We're going to explain the program, and if they're willing to engage, they'll just give us a consent release of information so that we can go ahead and start advocating for them. We'll provide fentanyl test strips, overdose education, and Narcan. And then get them connected with any MAT that they need. This little video, sorry. The EPIC coaches are expected to contact clients once a day for the first 10 days post outreach and 1 time a week during the remainder of the program. Usually when someone gets more stable, where they've already built their supports around them, it would go to maybe every other week or once a month. Never is it longer than 30 days. A client who agrees to participate in the program are not required to engage in substance use treatment. They can do just a recovery coach. They can do a recovery coach and substance use treatment, or a recovery coach, substance use treatment, and medication services. Regardless, all clients referred will receive overdose education and Narcan kit. And then clients who initially agree and consent and subsequently disengage from services will be discharged from the program after 30 days of no contact. And that applies for any of the options that they go with. And here's us. That's Sean. He's the Vice President of Substance Use Programming, Sean Billings. I'm sure a lot of you may know him. That's me in the middle. And then Yoshua Medina is the manager of substance use programming. It's recently been merged over to Carrie Weniger, and Yoshua's working with another region now. So does anybody have any questions? Yes.
Terrific presentation. Thank you very much.
Thank you.
Is it just, sort of heroin, oxycodone, things like that? Or what about, methamphetamine or, cocaine or PCP or other sort of drugs of, drug use disorders?
Well, interestingly enough, we have not seen heroin in a really long time. We're getting fentanyl, but we do take multiple substances. It's not just the fentanyl or heroin. We have people that maybe they're using alcohol and PCP, or alcohol and cocaine and crack, or, it's a lot of people are polysubstance, but we work with all of them. When I first started, we did just opiates, and it was very disheartening when I had to tell someone, are you sure you're not using opiates? Like just a little bit, because I wanted to get them enrolled in services and I couldn't. So now that we're able to do that, it's making a huge impact in our community.
And anecdotally, you don't see much difference in the benefit of the services you offer by drugs being used?
I don't think so. I think if there is opiates and alcohol and we do get them plugged into MAT, there seems to do better as far as longer stability. But no, I mean, I have noticed recently though that we're seeing an uptick in cocaine and crack. I haven't seen that in a while. Have y'all seen that?
No, but that is trending.
Yeah, it's trending upward, so. Does anybody, yes.
So sometimes finding housing for someone is a real challenge, or finding some of the other resources that someone needs may not even exist, despite the, community kind of being perceived as an oasis of resources. How do you help when you can't find the resource to house someone, particularly folks who are rather difficult to house because maybe they've lost housing repeatedly and some of the places you might normally turn for housing are not an option for those folks? How do you manage through all that?
Sometimes there's a lot of begging involved. I think building community partners is a huge piece of having successful placement for people when they're eligible outside of other things. If they burnt those bridges, I have seen multiple times where me or the coaches will call that agency and, hey, I've seen these behaviors out of them recently. These are the things they're doing different. And sometimes they'll change their mind. We had a gentleman get kicked out of housing the other day because he had a reoccurrence. He did not bring drugs there and they wanted him to go to detox. He didn't need detox. He just needed to get back on his Suboxone and he would be able to continue his recovery. And the first person was like, no, absolutely not. He needs to go to detox. And it wasn't an option. Well, the coach called the person over him that we have a relationship with. She was like, get him on his medication. I'll deal with the staff member. And so I think building those relationships is one of the biggest pieces. If it's something like medical wise, which we have seen a lot more medical comorbidities where it may be outside of the peer scope of work, we will lean heavily on social work through the hospital or the ERE and anyone that has the medical piece, and then we'll offer the recovery piece. Is anyone any other questions?
Hi, is there time for a quick question from online?
Oh, I'm so sorry. Yes.
No worries. Hey, it's Miranda Klink Ferguson. I also have a new last name since we last spoke. I was previously an engagement specialist with EPICC. Great to see you.
Good to see you.
I have recently noticed billboards for EPICC around town, and I was curious if you've seen an uptick in referrals since putting those up.
So we have seen an uptick in referrals just consistently month over month. As far as since the billboards went up, I will have to check with, there's somebody else who handles that piece of it. So I don't know if it's directly related, but the billboards are awesome. If you guys haven't seen them, just keep your eyes out for them. Thanks for noticing.
Cool, thank you. Yeah.
I was telling people I dropped my daughter at the airport to leave back out of state and I'm emotional and I'm crying. I'm going down I-29 and I see the billboard for EPICC and I'm like, oh my gosh, it almost caused a wreck. But I was so excited. So my tears turned to joy real quick. Are there any other questions from online?
Good afternoon, everyone. Just real quick, since we had a question about referral prevalence, and I'm mid-step in writing our annual report. So Western Region specifically realized a 44% increase from the last state fiscal year. So that's from July 1st to June 30th. So, I mean, that's pretty significant. So 44% increase. And I think that's around 873 referrals that Western Region received this last state fiscal year. And one quick question for you, Jen.
Yes.
Can you speak just briefly about the increase of pregnant mothers being referred to EPICC and some of those challenges, right? As we try to build skill set in the workforce and just try to serve mamas stuff.
Correct me if I'm wrong, Sean, the Western region has seen more pregnant and postpartum referrals than any other region in the state. And it has increased month over month. Last month we had 13, which was significantly higher than what we were used to. And we noticed this trend about 6 months ago, I believe, where it started trending upwards. And so getting our toolbox bigger and fuller was a necessity. And we've had really good success with advocating for these moms with family and children and family services, because there was a lot of them that have involvement. And Some of the challenges that we've had are, well, placement, housing placement. We had one that was in treatment and drank a couple of days after getting there, and then treatment was like, well, you can't be here. And so that's been a struggle. And then getting placed on a Friday afternoon for someone who's pregnant, and some of the houses, they want money because you have to have money to operate. So it has been a challenge, but we're figuring it out and we're making it work. I don't know how, but the powers that be have worked it all out for the people that we're serving. Okay. Were there any other questions from online?
Just a comment. You do wonderful work and I appreciate you so much. Just want to say that. Great job presenting, and yeah, can't say that enough.
EPIC is near and dear to my heart. I lost my boyfriend to an overdose in 2015, and I knew in that moment, after I got my life together, I was going to be in this line of work, and here I am. So thank you.
Great, thank you so much. Now. There we go.
Minimize that afterward.
And, all right, so now we'll turn it to the next presenters, who are a group of our researchers who are going to be presenting on assessing impact of mixed method evaluation of the Kansas City Engaging Patients Care Coordination long-winded opioid peer recovery coach program. But yeah, I'll let them introduce themselves in turn, but I'll start your slides there. Maybe, there we go. All right, thank you.
Well, good afternoon, everybody. My name's Holly Hagel, and in fact, I'll show you all the presenters you're going to see in a few minutes. I'm just going to take 5 minutes to give you sort of a higher level overview. So this is the research team that's been working together for 4 years, you guys. It's been weird 4 years, right? It's been a long 4 years too. And this is what we plan to cover. I'm doing the setting the stage, and we'll review the quantitative, qualitative things, also economic overview, and that's the value case for the different collaborators. So there again, there's our whole entire team. So we've been referred to as the opioid team for shorthand. And you can read about it on the High IQ website. We have a little space there as well. These were the hospitals that were involved that Dr. Farr mentioned, the C-suites and all the methods, the research methods and the collaboration and communications that went on that set the stage. And these were the hospitals that we engaged with for our project. And I just want to start by intentionally rereading the title, because this is a reflective piece for us. We're closing out this piece of work. So this has been assessing impact, a mixed methods evaluation of the Kansas City Engaging Patients in Care Coordination, KC EPICC, here opioid peer review coach program. I don't usually read slides out. I try to avoid it, but I wanted to be intentional as I present the overview to you guys. So yesterday and for 2 days, I guess, we've been talking about what we wanted to present, the sequence and everything. And it made me reflect, and an image came to me because we are being reflective of a long and winding road. So you can see this is beautiful scenery on either side of that road. No HOV lanes. It doesn't look like there's any road shoulder or guards, but it looks like a beautiful destination we're heading to. But it was long and windy, and I would say that's sort of kind of our experience. Maybe you guys will disagree or agree, but that was what came to me. And besides a long and winding road, we sort of traveled the road less traveled in a way. It is very, very, very unique, and maybe Dr. Spurtis will talk about this, that we have an opportunity to work with so many collaborators, payers, hospitals, the community, Jennifer, people in need that really opened their doors to let us do this evaluation project. So that is the executives. And one key implementation principle, you would say, is that you have to have leadership buy-in. It's essential. If we didn't have the buy-in of those leaders, they wouldn't have answered my email for sure. But not only do you need a leader, you need a champion. And I want to say, in my opinion, and I think our research team agrees, that champion was the Missouri Hospital Association. And Sean's going to present soon, so I'll let him speak to that. I think we all know Sean. But when we would say, hey, we're working with the Missouri Hospital Association, people immediately trusted us, all the executives. So it was the hard work of Dr. Spurtis, Dr. Spar and their team that made these executives buy into this. One of the tools that we use for understanding the project is a tool called the process map. I'm not going to belabor this. We have recordings of previous forums in which we presented this work. I just want to read and be intentional about what this tool is. This tool, process map, is an implementation tool that assesses a site's context, either before or selection or tailoring of an evidence-based practice. So we came in and the hospitals were already, KC EPICC was already running. So for this particular, process, they were already up and running when we started to do our evaluation metrics. And just to finish out the definition, the strategies that you're hoping to get through by doing process mapping is to increase the adoption and sustainability of that practice. When all those grants go away, is it going to be meaningful to last long-term? Okay, so I'll stop there with the definitions because they're kind of boring, I'm sure, but thanks for engaging with that. One of the things that we did, and I hope you see it in the data analysis too, is we had the opportunity to get a lot of feedback. We got feedback when we did these process analysis maps because you talk to the people doing the work. You map it out, then you talk to them and say, is this correct? And then they make adaptations. Obviously, a qualitative component was getting feedback from the people in the system, people utilizing the project. So we got the feedback from the C-suite. So feedback, very, very important. And this was also a real life evaluation, right? This is not clinical trial within a lab. So feedback is important. Now let's do something fun. Just indulge me here, you people online too. When I say, give me a, you say letters. Okay. So give me a,
T.
give me a,
U.
give me a,
A.
what's that spell? Duo? No, actually, it's just to make you laugh. It stands for data use agreement. All I'll say about that, and maybe we could talk and chat about that at the end, is that it's necessary. It's vital. It's very important. We want to protect confidentiality of people. However, it may take a long time. And so I think that was part of the broad scope of our project, is finding out how complex that could be when you have so many collaborators, which is a good thing. That's that road less traveled. Okay, 2 more slides and I'm passing it over. I wasn't counting my time. Okay, last thing. Does anybody recognize this picture? What is it? No? Anyone? COVID. What do I have to say? Nothing more. The picture says it all. We started in 2020 and COVID started. So, right, we know everything changed for about 2 years. We're in 2024 right now. What I will say about COVID is, obviously it changed how we were living and working and doing everything for 2 years. And it's still going on, right? But we're back to normal. Look at us. We're all in this room together today. But for people who use substances, in particular during this time, they really suffered. And substance use, opioid overdoses increased in a very high rate during this period. So, this work obviously is to help and impact people who need and want help. So I'm going to end here talking about the mixed methods data by saying this. It takes many hands. Many hands make light work, many hands to build that road less traveled. And at the center of this many hands and groups and collaborators is this desire, genuine desire to increase care for people who use substances, for people who choose or want, or maybe they don't want to change their use of substances, but we can still care about them. So I get the pleasure of introducing my colleague. I think Dr. Olds is coming up next to show you the data.
All right, thank you so much, Holly. So I'm going to talk a little bit about our quantitative analyses, and these are not exhaustive of all of our findings. We have just a ton of data. So these are just some highlights that we thought were sort of interesting. So as Holly had mentioned, our data from April 2019 through May 2022. So this might be a little bit older than some of the more recent findings that Jennifer was mentioning. And some of the things I'm going to talk about are referral locations. So which healthcare services are referring the clients? Client characteristics, so who is EPIC serving? Client needs, so what are the health and social needs of EPIC clients? EPIC engagement, so what is the engagement in MAT and EPIC services? And then a little bit about healthcare utilization, so what is the hospital and ED use of EPIC clients before and after engaging with the EPIC program? So EPIC referrals, in our data set, we found about half of the referrals came from hospitals. And this isn't surprising because it was really started as a hospital-focused program. But as Jennifer mentioned, there's been a lot of referrals from other and self. And that's followed by behavioral health agencies, hospital-based behavioral health, EMS, and integrated health centers. So I'll break those down a little bit more for you. So in terms of hospitals, UH Hospital Hill was the largest referrer, followed by North Kansas City, and then University Hospitals Lakewood. For other and self, actually the bulk of those was other, and then there's also some from self. For behavioral health agencies, Rediscover and Comprehensive were the two highest referrers in that group, followed by Heartland and then Tri-County. For hospital-based behavioral health, there's really only one, University Health Behavioral Health. And then for EMS, I know EPIC's had an increased focus with the EMS as a referral source. American Medical Response had the most, with other EMS, and then Central Jackson County Fire Protection had one referral. And then finally, for integrated healthcare centers, SWOPE referred quite a few clients, and then Preferred Family Healthcare referred one. So EPIC program engagement, we found that about 77% of those who referred to the EPIC program actually enrolled in it, which is just a tremendous success. And so we wanted to know, are there differences in those who enrolled versus those who did not? So would there need to be maybe some targeted efforts towards certain demographics to sort of move them from being referred to being enrolled in the EPIC program? And we actually found that there were no differences with the demographic characteristics. But I do want to share with you some of the characteristics of the EPIC clients. So the majority of them are male and white. One thing I will highlight is that there's quite a bit of missing data. This is quality improvement. This is real world data collection. This is not nice, neat clinical trial data collection. You know, a lot of these folks are in crisis, and the peer recovery coaches are trying to establish a relationship with them first and foremost. And so a lot of the data might be missing for some of these variables. So a little bit more about the EPIC clients. So about 45% of EPIC clients are unhoused. For employment status, about 74% are not employed, but interestingly, almost 18% are employed full-time. For insurance status, 62% are uninsured, followed by about 21% with Medicaid coverage. And again, there were no differences between enrolled and not enrolled for these demographic characteristics. So for client needs, of those who engaged in EPIC services, 63% reported to their peer recovery coach that they needed housing. About 49% needed transportation services. Almost 25% needed cell phone or internet or some sort of communication. And then 5.4% needed childcare. And again, these data are through May of 2022, and with an increase in the pregnant population of EPIC that this might increase quite a bit over time. And then almost half had other needs. For healthcare needs of EPIC clients, 44% needed mental health care, 41% reported needing primary care services, and then 5% needed reproductive care. And at the time that these data were collected, about 4% were pregnant and about 3% had given birth in the prior year. So we know that a key to success with opioid use disorder is having MAT, and a bridge prescription for MAT really facilitates clients acquiring that. And so we looked at the percentage of clients who were given a bridge prescription for MAT, and it was about 19% overall, but it was 23% for those who were enrolled in EPIC. And so the peer recovery coaches really helped to facilitate that. One thing that's interesting, a key part of the EPIC program, as Jennifer mentioned, is providing overdose education. And 92% of EPIC clients received, who were enrolled, received overdose education, but 71% of those who chose not to enroll in EPIC were still given opioid overdose education. And that's really important to show that the peer recovery coaches not only make an impact on people who enroll in the EPIC program, but also those who choose not to enroll. Similarly, for naloxone kits, almost 35% of people who did not enroll in EPIC were given a naloxone kit, and that's really important, with overall over half receiving a naloxone kit. So for client engagement in MAT, this is the percentage of those who were enrolled in EPIC who were receiving MAT at the different time points. So one question that we had is, of those, do those who receive MAT engage in the EPIC program longer? And so we looked at, first we looked at time in the program. And so you'll see that about 26% of those who enroll in EPIC are in it for 30 days or less. They may receive the services that they need and may no longer need EPIC, or they may lose contact with their peer recovery coach. They could pick up contact at a later point in time. But for this data collection, 26% were enrolled for 30 days or less, with 35% enrolled at 30 days, about 20% at 3 months, 13% at 6 months, and then 6% at 12 months. So then when we look at MAT, we find that clients who were receiving MAT were engaged in the EPIC program for much longer. And you can see here that at 3 months, you have, it's 34% versus 14%. And then you can see that as time goes on, it's a larger percentage of EPIC clients are engaged in MAT. And you can see that here as well. Another important question is to look at healthcare utilization. One thing that we looked at was of those who are enrolled in EPIC, what does their ED utilization look like before and after engaging in the program? When we looked at all clients who were engaged in the program, we found no difference. And a lot of that's because people who were not using the ED much before were also not really using much after. So then we focused on those who are considered to be have high rates of utilization of EDs. And in the literature, that's those who have 4 visits or more per year. So when we limited it to EPIC clients with 4 or more ED visits per year, we found there were 211 of them. And after they engaged in the EPIC program, they had about 3 fewer outpatient emergency room visits per year and approximately 1 less inpatient hospital admission per year. And this is huge. There are a lot of programs out there that try to decrease ED utilization among those who are high utilizers. And so this is a really important finding to help support hospital engagement in this program. It's also important for those who have insurance, because the average copay for an ED is about $500. In Missouri, you can add on another $750 to $1,000 if there's an ambulance. And for those who are uninsured, which is many of the EPIC clients, the average out-of-patient cost for uninsured is almost $2,000. So that's a huge financial burden for them. With that, I will turn it over to Dr. Tracy LaPierre.
Hello. So I'm going to be talking a little bit about the qualitative analyses. I'm going to, instead of having slides that have nice pictures professionally done, I've crammed on a lot of text, and I'm probably going to talk a lot faster than some other people because I want to say so much and I have so little time. I'm barely scratching the surface of some of what we were able to identify and determine with the qualitative analyses. But I'll start briefly by just saying, here's who we interviewed. Interviews started in, I believe it was October of 2020, and we wrapped up interviews in December of last year. We interviewed 13 hospital staff across 4 hospitals. We had ED directors and supervisors, physicians, social workers, qualified mental health professional, and addiction and recovery services coordinators represented there. We also did interviews with MHA and CompCare leadership and other staff, peer recovery coaches, and clients. So one of the things that was really important with this project is that we get input and feedback from a variety of stakeholders in this process that are engaged with the EPIC program. Our goal was we had a lot of goals, but we wanted to know what was working well, what wasn't working well, what were people's experiences, what were their needs, to do an evaluation, give suggestions for improvement, and try to find areas that could be targeted for making, I guess, breaking down some barriers, as has been mentioned. Today, I'm going to focus on highlighting a few of the high-level things or some of the successes of the program. Another goal was to look at definitions of success, because we wanted to show the value of the program using different metrics. And so we asked each of these different groups of stakeholders what their definition of success was for EPIC or for recovery. And we had a variety of responses that kind of expand our way of thinking about what success looks like. For some, it was moving clients towards recovery. That could be measured in terms of number of referrals or harm reduction, or being engaged with a peer recovery coach. Some were substance use specific, fewer ED visits, engaged in treatment, days, months, years of sobriety. Those are the more standard ones that we're used to seeing. But there's also the broader impact on quality of life that was really important, especially to the clients. And many of the professionals that work with them also recognize this. EPIC has had an impact on reconnecting with family, maintaining or regaining custody of children, employment, having a car, all these different other areas of life that can be viewed as measures of success, that things that were achieved because of engagement with EPIC. I have a couple of quotes. I feel often like it's a victory if the person is able to spend time and energy toward even simple things that will enhance their health and well-being and enhance their relationships. I feel like it's a great step forward if the person communicates with their support system when they have a relapse, when they're actually tempted to relapse, when they're transparent and tell the truth. To me, that is a greater gain than just flat out statistics of how many times you've relapsed or how long you've been sober. That was a qualified mental health professional. We also have, I think that the success is in the referral count, because people know that we're here and they know what we're doing and they see it in the community. And I think that number will reflect it. But at the end of the day, the success is keeping someone alive today. That was a peer recovery coach. And a quote from a client: "Success for me looks like having a stable job, a stable home, just doing bigger and better things, advancing my life." So obviously their recovery is key to achieving those things. So what's working well? Easy process for referral. Here's a quote: "It doesn't feel laborious on our end. I think participating with EPIC is easy and seamless for us. It just seems like a no-brainer to participate." This was one of the director of emergency services that we talked to. Peer recovery coaches with lived experience. That's a key feature of the EPIC program. You knew she came from where I was coming from, and that was really helpful to me. You can't beat that. You really can't. You can tell when someone's been through those things or when somebody's empathetic towards those things and knows how to deal with it and has the confidence and doesn't look at you. They look at you like your life is like you're worth it. So that was from a client. Timely response at all hours. That quick response time is something that works really, really well, especially with the flow of the emergency department. Warm handoff. I think it's critical when people have just detoxed and they're out of their using environment, if they're expressing an interest in treatment, to get them into treatment as quickly as possible and to not allow any lapse where they can easily use again. The fact that they would have everything set up, that the peer recovery coach would come, pick the patient up, bring them directly to the clinic, get them established. I think this population really needs that. And there were a number of people recounting how important it was to have their peer recovery coach come pick them up from detox and bring them to their first housing that had been arranged for them, and things like that. Individualized support and case management was critical. For example, one client felt that truly taking the time to decide what services will help this individual in particular, that will help set them up for success, was an important indicator of the quality of services the peer recovery coaches provide. She said her coach did a pretty good job explaining. She asked me a lot of questions just about what my particular struggles are, what my triggers are, what my needs are, what's most important to me about my recovery. Clients that I spoke to that had been engaged in other types of treatment programs before really commended this and really felt like that was something special about the EPICC program, that it was really individualized to meet their specific needs and provided support in so many areas that are overlooked in other recovery programs. Connections with service providers in the community. It's the things we can't replicate. I don't have those relationships and connections with the service providers in the communities. That is really essential when you're trying to get people into timely follow-up. That was one of the qualified mental health professionals. Other things that were working well included help with social determinants of health and other practical assistance, such as transportation, getting them set up with housing. There's frequently comments about housing, how you would need a week's rent or whatever up front, and somebody who might be coming out of jail or previously homeless or just trying to get their life back on track, that could be a real barrier to getting into a sober living environment. And so EPICC being able to help with those things, helping with food, these necessities of life so they could focus on recovery and getting their life back together, clothing, assistance with legal concerns, child protective services, employment, etc. These peer recovery coaches helped with anything that that was a real need that could benefit the clients in their road towards recovery. One other theme that I'll bring up briefly is the use or opioid overdose reversal medications and medication-assisted therapy. As you heard in the description, those are core features of services that are provided by the EPICC program. And these are types of services that in some other treatment type programs, they're either not supported or they're actively prohibited. So that I think conveying the importance of these types of medications for recovery is important. And these are some things that came out in the interviews. This was a medical director of the emergency department at one of the hospitals said, peer recovery coaches have the ability to give them Narcan, and they have the ability to get them into a Suboxone clinic, which in my opinion, those are the two things that will save lives and help with treatment. Other peer recovery coaches and people who have used medication-assisted therapy have talked about how critical that has been for their recovery. One of the lead peer recovery coaches that we interviewed recounted this to us. Narcan keeps people alive until they're ready for recovery. I can't help someone who's passed. So everybody gets Narcan. They either get it from the hospital, they get it from us, they get it from treatment. We re-give it to them and re-give it to them. I had a coach that had a client who just couldn't quit using, and he would actually reach out to her on a regular basis and say, I'm not ready yet, but can I get some more Narcan? And now I believe he's at 9 months in recovery and doing amazing. But for the first 6 months, she stuck with him, and basically all she provided was Narcan, but it kept him alive until he was ready to step into recovery. Yeah, Narcan is huge, huge. So this some people are not happy with this as a harm reduction method because they feel like it's enabling. So this demonstrates that it's not enabling the bad behavior, but helping them get to a place where they can then enter recovery. I don't have time for this quote, but it was really great. I have a shorter version here from a different client who says similar things. So again, on the side of the client who's receiving medication-assisted therapy, Suboxone has done a huge positive spin for me. It's taken my thoughts of drugs away. It's taken my craving. It's kept me focused and doing what I need to do instead of doing what I don't need to do. Let's say that. And if it wasn't for Suboxone, I probably would have never picked up the phone to call my peer recovery coach, to have my peer recovery coach help me, because I would have, and I'm sorry, it doesn't matter who you are. You can have $1 million. I would choose drugs over you. That's how being an addict works. You will do whatever, hurt whoever, go wherever to get that drug. And Suboxone has taken that wherever, whoever, whatever out of my way. And so I think that's a powerful message in terms of the role that Suboxone and how helpful it can be in the recovery process. Even the other client that I had a quote from talked about how they were one of those people that was kind of against medication-assisted therapy, right? I don't need another drug to be addicted to. And how that once they were better educated about it and gave it a try, how life-changing it was. The overdose reversal medication, we saw across our interviews that it was widely available, very accessible, especially in the Kansas City area. So that was great, but there were still barriers to accessing MAT that were improving, but still persist. Some of those were physical barriers in terms of getting prescribers who at that time would provide or would get waivered, would provide bridge prescriptions, or finding a treatment center that had openings. But there were also attitudinal barriers that were identified. And here's a quote just talking about how Narcan saved their life because of the easy access to it. But here's one of the addiction services coordinator talking about why some physicians may have more referrals to EPIC than others. Honestly, I think it comes down to if they're believers. And I think when they think of EPIC, they think of Suboxone, that connection. And I know some personally that they're not all about it and think everybody should just not be on anything. So there's still some biases there in the attitudes of people who work in the emergency department that could be potential referrers to the program, and also maybe a lack of understanding of the program that you don't have to be on medication-assisted therapy. That's just one aspect, and that EPIC will support people in many ways through their recovery. And another one, there's so much stigma surrounding Suboxone. I explain repeatedly to people, like, forget what Joe Blow was saying out there about this medication. Are you going to tell someone because they ate those cookies they can't have insulin now? No. And they need that to maintain their life and their livelihood. So peer recovery coaches work really hard to try to reduce that stigma and educate people about medication-assisted therapy. There's a number of themes that I don't have time to get to. These are just a couple of highlights. Some of them we brought up at previous presentations, but we have a lot of data on barriers to referral and treatment, impact of COVID, EPIC outreach and training, peer recovery coach roles, rewards, challenges, and needs, client resource needs, and recommendations for expanding and improving EPIC. And I just wanted to end on a couple of quotes that are related to the theme of gratitude that kind of illustrates some of the impact or feelings that clients had about the program. This is a program that is definitely a life changer. It gives you the ability to realize that you're capable, what you're capable of with some support, whereas some programs look at you as if you're incapable of doing these things on your own, when really that's not the truth. You just don't know your own power yet. You don't know your own capability yet. And EPIC definitely helps guide you in that. And I'm so grateful. I'm so grateful for my caseworkers, because honestly, if it hadn't been for that, I don't think I would have ever realized my capability, because I was so used to being enabled, not empowered. There's a huge difference in it, and I'm grateful to now know what that is. And another client says, and EPIC saved me. And if it wasn't for them, I don't know where I would be. So I'm very, 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 very thankful. To be 100% honest, I think EPIC is EPIC. They deserve their name. And I'll end there. Thanks.
Can I just say, I appreciate the data, that was so powerful, and I really appreciate y'all sharing that was so good.
There's lots more.
Like I'm over here fighting tears. Like I'm so proud of this program. So thank you.
Thanks. Hi, I'm Kate. I was going to talk about some of the value cases from various perspectives of people involved in this work that you do. From an economic perspective, but much more so from a qualitative perspective, partly because we don't have I don't feel like we have enough data to talk about the true savings. There's been a lot of work done that shows that these types of programs are cost effective. But that's not what I'm going to talk about exactly now, although I will touch on some of the metrics that we could look at hopefully in the future when we have a data update, so that we can kind of put a dollar amount or return on investment for you to this program. So when I'm talking about the healthcare system and provider perspective, what I'm really talking about is hospitals. And there's really almost no cost or time burden to the hospitals to implement the EPIC program in their ED. But in exchange, the program provides hospitals with a number of savings from operational efficiencies by lowering admits and length of stay. So addressing that throughput that hospitals are always really concerned about, and reducing the use of the emergency department, as we already have been able to see. Lowering prescription drug costs, reducing the cost of neonatal abstinence syndrome treatment, avoiding CMS penalties, potentially avoiding liability litigation for treatment or non-treatment, and reduction in charity care costs for uninsured and Medicaid patients. Hospitals might also expect to see revenue from payment for rehab facilities or partial hospitalizations, and for an increase in outpatient services, such as labs and primary care utilization. But on top of these, measurable value sources, there's also intangible value from the peace of mind that providers get from knowing that they're handing their clients, their patients off to somebody who's going to really help them, direct them to care. And I believe that probably there's also some improvement in health literacy for the patients who are getting involved in the EPIC program, which again will kind of help with operational efficiency and just making workflow easier for providers as well. Of course, we've already talked some about value to the recipient and to caregivers, access and connection to services that help sustain recovery as part of that social capital, and improved addiction understanding and health literacy that helps sustain recovery. So both of these are measures of recovery capital that we expect to go up for clients. Life expectancy, because the risk of overdose is going to be much lower, and health-related quality of life benefits we expect to see. Individual empowerment and the ability and resources to address social and other competing health needs, such as seeking more preventive health care and reducing inpatient and emergency visits. I just sort of threw in there, sorry, the font changed, about the outpatient cost being about $1,800, as Danielle touched on. Improving the ability to return to work or engage in the workforce again. Improved independence frees up caregivers, allows them to work other jobs and have less stress in their lives, and also significant savings on, the cost of their addiction. And I pulled up this website, addictioncenter.com, and they have a little report on how much do drugs cost, and just hit some of the high points. Oxycodone, which is a very common prescription, if taken 3 times a day without insurance, is over $3,000 a year bought on the street. And of course, 3 times a day is only going to be enough at the beginning. These people are going to continue to add pills daily, raising the cost of their addiction quickly over time. We're going to talk about heroin because apparently it's not a thing right now, but it's very expensive. And meth is a single dose at about $5, and somebody with a severe addiction could spend up to like $40,000 a year on meth. And these are, again, 2016 prices, so 8 years of inflation would probably increase a lot of that. And we do know from the ComCare data that a lot of these people are polysubstance users, so they're going to be, spending on a variety of drugs. So, and then, EPIC takes you regardless of ability to pay. So that's just a huge economic relief, I would think. Peer recovery coaches who are engaged in the program are offered in employment where they may have had done before at a competitive salary higher than the minimum wage in Missouri. And what we saw in the qualitative analysis was that the work that the peer recovery coaches do, they consider to be very meaningful. So I have a couple of quotes here. One is, my duty to the universe is to get out there while I'm still alive and to help somebody, because I was saved from being dead in 95. I convinced myself that that was for a reason, and that's my job now. I believe in higher authority and the energy around us and everything else, and I'm a part of the energy, and I want to do good. And another peer recovery coach was quoted as saying, I consider myself here for a mission to do, and this is my mission for whatever time I have left in this world. So it's a real calling for me. And so that's why I take it so heavy when I miss the opportunity to be able to help somebody. So there's a real connection there. And, you know, it's really valuable to care about the work that you do and want to show up. I'm just going to talk very briefly about value to payers. A recent analysis showed that for the year after diagnosis with opioid use disorder, private insurers ended up paying about $17,000 more than for somebody without such a diagnosis, and Medicaid pays $19,000 more. So addressing opioid use disorder will save costs for payers as well. And then value to society, there's a lot of different metrics out there, a lot of literature, a lot of it is, you know, from different time periods and has different components, but generally they agree that there's cost savings to engagement in opioid use disorder treatment along the lines of $25,000 to $100,000 savings per person over the lifetime. Once you factor in criminal justice costs and other costs, those really offset the costs of rehabilitation. So some components of that cost saving include improved workforce productivity. And along with that, as people are more able to work, there's going to be improvement in insurance coverage. And with the improved insurance coverage, there's a reduced taxpayer burden on paying for medical health care for uninsured and Medicaid patients. In general, I think the EPIC will contribute to a healthier population as people start getting more preventive services, hopefully improved health equity and quality of healthcare, trust in the system and providers. Additionally, as Tracy mentioned, there's preservation and reconciliations of families, which is a societal value, reduction in homelessness. The initiative aligns with federal initiatives for harm reduction. And the infrastructure that you're building is going to help improve preparedness for future substance epidemics like tranq and other things coming down the line. And improved community safety and well-being as we reduce substance use in drivers. And stigma reduction, of course, is a huge value, and we've seen in the HIV epidemic and things like that, that the more we can reduce stigma and get those billboards out there, the more likely society is to agree to harm reduction strategies and pave way to better policies. So I just wanted to end on this peer recovery coach quote that I really liked because it kind of sums up how valuable they are and what they really do. So this one said, I call myself a barrier buster. I bust down the barriers for clients. That's it.
One more speaker.
Oh,
Sean.
no, I didn't know that. Okay.
He's online.
So I'm going to stop sharing and let Sean speak.
Yes, thank you. Yeah. Sean, you're up.
All right. Well, let me find the slide deck. Let me do it from the beginning. Okay, what does it look? Does it look good?
Yes.
All right. So good afternoon. Wow. All of that information I'm still processing, but yeah, it's a real testament to the wonderful work that our coaches do, right? They drive this work, make no mistake. So good afternoon again. A lot of things have been covered. let me see what I've got here. Before I get to this, I don't have a slide on where we began, and I'll keep this brief. So EPIC was launched in the Eastern region in December of 2016 under the leadership of Wendy Orson at the Behavioral Health Network of Greater St. Louis. We started off with 2 certified peer specialists. And the first month, we had 3 referrals. So fast forward to 2024, after MHA took the good work of BHN, replicated it throughout the state, now we have 43 certified peer specialists serving within a lot of different pockets, regions in the state. And our average monthly referral volume, which is a conservative estimate, is around 450. So we still have a lot of work to do, but we are reaching a lot more community members over the last 7-8 years. So that's just a high-level brief history of sort of how we got to this point. So I'm not going to belabor this. Jen did a great job describing it, but if we were an automobile, the chassis of our program, it is built on an S-BIRT frame. That's how we serve. That's who we are. One update, Jen had a map, but thanks to Senator Holly Rader last legislative session, she took some money and appropriated some dollars so we could expand EPIC into the boot heel. And as you can see, all highlighted there in green, we're able to get, I don't know, what is that, 8, 9 additional counties. Tremendous work taking root down there. Really good stuff. And then this right here just gives the hotline numbers. As you can tell, we have a lot of work to do in that gray area. This is just the referral criteria across the state. You will note most of them are adults with some serving some younger populations, but that's very niche, and those are outliers. So looking ahead, you know, we talked a little bit about us being able to serve in the space of maternal health more. And I don't know what has taken root in the Western region in the last 18 months, but I have some ideas. But I do know this, we are getting more mothers that are pregnant being referred to our program. And one of the core reasons, I think, of why agencies, to include hospitals, all of our wonderful ADA providers, community-based organizations, the reason why they're leaning on Jen and her workforce, the peers, is because they trust them. And they know when they refer these women that they're not going to fall through the cracks. So as that word gets out, they're leaning on us more and more. And I see that in pockets throughout the state. Picking on our friends down the boot heel real quick, they have been very intentional to get in front of our friends at the Children's Division. And within the last, I would say, 6 weeks, they are now being invited to attend family support team meetings. And if you're not familiar with those, when Children's Division takes and removes the custody from the children of the parents, they have to have these family support team meetings basically to give progress reports, updates. How's mom? How's dad doing? And they feed that up to the court. I used to be in those meetings. It's been a long time ago, but I used to serve at the juvenile office. And I'll tell you, in those family support team meetings, the missing advocate was for the mom, was for the parents, right? You have the guardian ad litem, you have the court-appointed special advocate, the juvenile officer, Children's Division. So the peers are being invited into these FSTs to advocate for mom. And I just love, love, love that. And I think it's going to pay off as far as helping mothers, families reunify back with their children or their child, preserving families. I just see it as a win across the board. So I just want to make that point. So expanding screening, brief intervention, referral to treatment. Obviously, that is what we live and breathe. Tremendous opportunity to embed that a little bit more successfully within our hospitals and just really everywhere. Hospital-based peer health navigators. If I could wave my wand, when we identify and secure funding, this is going to happen, right? We want to gift our wonderful hospital friends a peer workforce for them to serve within the 4 walls of the hospitals, just to help the clinical care team to augment the case managers, the licensed clinical social workers. They're also, working on behalf of the consumer. But those peers in the hospital, they can advocate for community members with use disorder in a much different way. And I think we've seen some of that, the sentiment, the qualitative data that was shared that speaks to that. Expansion and enhancement of, so if you're not familiar with this, the Centers for Disease Control, and this has been many years ago, they pushed out a grant, a funding mechanism that many of the states in the nation can benefit from, Missouri being one of them. It's overdose data action. I'm not going to spend a lot of time going over it, but what this does in part is it's beefing up biosurveillance within targeted hospitals. The reason why I put this on the slide deck is because we are specifically targeting EPIC hospitals to basically embed this new program. And really what we're trying to do is Sean Billings lands, let's say University Health, triage, stabilized. Part of all of the other wonderful things going on is they're going to basically take and scrape some of the plasma off of the blood they've already taken. They're going to wrap that up in a cryo vial, and then they're going to ship it up to the Missouri State Public Health Lab, and then they're going to spin it to see what's in there. But in addition to packing up that cryo vial, everything else is still taking root, right? The screening, brief intervention, so they're providing some of the overdose education, naloxone distribution, maybe some other bells and whistles. And then they're also picking up the phone, initiating that referral to EPIC and starting that whole referral to treatment. Just to really expand and augment some of the good work that's already taking root. Overdose education, harm reduction in general is a core underpinning of how we serve. Not only do we dispense the naloxone through opioid rescue kits by the peers, but we're also concurrently working with targeted hospitals so they can stand up their own overdose education distribution program. To date, we have been successful to stand up one in North Kansas City Hospital, and we're currently working with our friends up in Liberty to do something similar. University Health is already serving in that space, so that's great. The question mark is just, you could put maternal health in there. I don't know how and when that's going to happen, but I do know this. One of my charges and something that me and my staff are going to be cheerleading this year on, and that is braiding our wonderful friends at the Children's Division into our clinical care teams. That means including them in our steering committee meetings, hopefully them including us in these family support team meetings, and really seeing how we can support and lift one another up. I mean, it's so critical. And over the 30 years of my professional career, there's been a lot of negative sentiment about Children's Division, both from a professional angle and, of course, from the community members who have their children removed, right? And at least in my small space, I want to do a little bit to improve that because I think they're an important piece of our broader teams. And I think by pulling them into the fold, we're just going to improve how we serve. So. Now, this young woman right here that hopefully is still in the room with you, she is wonderful, wonderful, wonderful. And the reason why I put this slide on here, not only to call her out, but that billboard that was mentioned, I think Miranda brought it up and so did Jen. I mean, this right here, this is her office, right? In the city, boots to ground. And that's who we are, right? Just really good work, super thoughtful. So I'm going to be quiet. I think I touched on everything, and I probably left a lot of things out, but I do want to leave 13 minutes for Q&A. And before I open it up, I just want to express my appreciation for the 4 years of work that all of you have put into the qualitative analysis, soon to be the quantitative analysis. I appreciate all of you very much. And I know COVID really threw a wrench in stuff, but yeah, I'm interested in getting my hands on that so I can put some of it in our annual report if we could. Anyway, just go around and cheerlead some more.
So thanks so much, Sean. Thanks so much to everybody. You know, the role of the Q&A at the end is sort of to contextualize and wrap up and then to take questions. And I just have to go off on a tangent here and just reflect on what I sat and observed. And, when we launched HiQ, these initiatives of bringing multiple stakeholders together with a research community to try and really improve the patient-centeredness, value, and equity of healthcare in Kansas City, it's sort of like Field of Dreams. You build it, will they come? Like, is it really going to work or not? And, I have this intense visceral sense that people do not appreciate what you just saw here. And part of it is the humility of our presenters. And I just want to give a quick anecdote. About 15 years ago, my neighbor was having a garage sale. And I keep saying, oh, I got to go over there. I got to go over there. It's Sunday afternoon, right? The garage sale's gone for 3 days. Nothing's left. I go there and I'll be darned if he doesn't have this thing called the planimeter. Now, nobody knows what a planimeter is, but it is about a $5,000 incredibly engineered device that you draw an outline and it tells you what the area of that outline is. And the only reason I knew is I was a cardiologist, and that's how we, back in the day before computers, used to figure out how severe aortic stenosis or, mitral stenosis was. And I look at this thing and it's $5. And I say to them, like, how could this be $5? Oh, people have been looking at that all weekend. Nobody can figure out what it is, and we're just trying to get rid of it. It's like finding a Picasso which everybody else looks at just a few scratches on the lines. And what we presented here is so easy to underappreciate what we've heard, and I mean, I'm thinking to myself, so, there was already recognition and praise for the qualitative insights that we've gotten. And, that is incredibly valuable. But it also can be so informative to the quantitative work. We saw from Danielle that people who were on MAT were in the EPIC program a whole lot longer. And you can never tell what's cause and effect, what's happened or not. But from the qualitative work, you realize that the Suboxone for that one patient who you shared the quote with, Tracy, had, could only stay in the program because their cravings had been abated, and so, that ability to bring together all of these different perspectives into a story. And, I'm looking at 3 less ED visits and 1 less hospitalization a year. Are you kidding me? Like, that is extraordinary. It's a mic drop. Well, it's a mic drop moment, and you dropped it like, oh yeah, we saw this, we saw that. I mean, Sean, you want to know what you need to be putting in your report. I mean, that is unbelievable. I mean, I participate in huge $100 million clinical trials, and we see effect sizes so much smaller than that. And we celebrate it and publish in the New England Journal and sing our praises to the high heavens. And you just throw it out there like, oh yeah, there were 3 less visits and 1 less admissions. That could be worth $1,000 to $10,000 for a patient. I mean, and the savings to the hospitals. I mean, there's no ER doc who says, there's just not enough action in our ED right now. And you can tell the hospital that by making more effective referrals, you could lose for every major opioid, person struggling with opioid addiction, 3 or 4 visits a year, 1 hospital bed that's being taken up that they may never get reimbursed for at the hospital sites. I mean, only 1.2% of the referrals came from St. Luke's Hospital. Who's going to St. Luke's and showing them that data? I mean, I think the challenge here, and Sean, this is going to be so valuable. We didn't have the time to go through EPA's process maps and all that, but for you to be able to package up the most efficient ways that the hospitals that were most successful, like Truman, in recruiting and contrasting that pathway with what St. Luke's was doing, or the sites that refer to even others. I mean, I'm from St. Luke's, so I pick on St. Luke's, but I'm not picking on St. Luke's. I'm just saying the insights into how you could roll this out into Springfield or other areas, and to have the data that Kate has formulated in what the benefits are from the hospitals, from the payers. I mean, the payers should be investing in this and really creating incentives because, the ACA programs and the Medicaid programs that they're covering could be saving a lot of the total cost of care. And we need a lot of creative effort to sell this. I mean, look, there's a candidate running for president who's selling much less substance than this. And we need to be figuring out, how do you package this up into a compelling story and leverage these insights to support a pull from the hospitals to want to do this program, because it's to their economic advantage. It's to the advantage of the ED to have, I mean, an ED is, every ED doc is so stretched, so thin, they're so overworked, they can't do another thing. But if this is saving 4 extra visits a year to their ED, all they have to do is, ask the social worker in the ED to call EPICC. I mean, all of a sudden, you change the whole motivation for participation. And when Stacy, Pat, Carol, before she retired, launched this, we dreamed that there could be a synergy between different people bringing different skills and different traits to a common problem facing our region, so that we could all become so much more effective and efficient. And this is the first time we've been able to roll it out. I mean, I know that there's twice as many people online that is here, but I mean, this should be paid to a packed stadium at Union Center in Chicago. I mean, this is really a big deal, and you guys really deserve so much praise, Sean and, the EPICC program for sort of being open and willing and believing in this, to support it, for the researchers who have worked, tirelessly without compensation to try and prove this case study. I hope this is going to get you really motivated to work with your Heidi colleagues to accelerate the data access and stuff, because this is how you're going to build out the economic argument that's going to drive your adoption here and throughout the entire state. And so, to me, I just need to take a moment to clap for all of you, because it's amazing, really, really amazing work. All right, with that diatribe over, other questions? Who wants to follow that?
I mean, I just wanted to make one more observation too, because in addition, because I completely agree with like what John has echoed, is like, we're talking about this, but like, these are big wins and we're still so early in the data, analysis, like, and we're still, needing a lot more control data, et cetera. But to me, the other part that was really phenomenal, besides like potential cost savings to different stakeholders and creating incentives and buy-in, what I think is really interesting is like the amount of engagement, not just the referrals, but like of those referred, the engagement over like at the 30 to 60 days, and then also those who are doing online IT. I just think that was significant, because when we launched this project, we were like looking at other kinds of peer recovery coach models that had been demonstrated in other conditions or other settings. And they were, I mean, this is a very difficult condition, like opioid use disorder is very hard to get anything above, what single digit, adherence to recovery service treatment or whatever. And just in the preliminary numbers that we have, I think it was like 30+% of it. I mean, that's a huge success that we're doing in these patients. So, I mean, it just gives a lot of like validation and satisfaction to the program. So, I mean, I know we have a lot more analysis to go, but that too was also something that we're really impacting lives. So,
all I can say is thank goodness this meeting was today. Otherwise, we'd have waited weeks, months more before finishing our analyses. Now we've done the initial round and we're motivated to finish it out, but it's impressive. I mean, yeah, please.
I'm hoping the next step in the EPICC journey involves getting hospital emergency room physicians to actually treat overdose by initiation in the emergency room. I mean, this is a crisis. This is an epidemic. And so emergency room physicians, I hear you saying, don't have a single other thing. Like, what else can we ask them to do? But they belong in this fight.
Well, you're highlighting, so now what we need to do is rerun the analyses by those where it was started in the ED versus not. And then all of a sudden you've got the data. I mean, this is the kind of input, like if that's what you think is the next important step in further improving the adoption of the EPICC vision, then we need that input to run those analyses. As we get that data, we'll be able to do it. Sorry.
Well, I just want to add to that. I love all of the preliminary conclusions. This is very positive. This is important. We know. I just want to highlight, maybe we perhaps revealed a little bit of a health disparity here, and that's something of note that we should look at as well.
I wanted to follow up on that comment about the ED providers and some of the other qualitative findings. You know, listening to the physicians that we're interviewing say that, you know, they try to gauge whether or not somebody is serious about recovery or not, and will only refer them when they basically are asking for a referral for recovery. And some of them are, it's in those conversations, some of the staff get a little jaded because they see some of these people come in again and again and again. And one of the things that came out, or that we were discussing that would be helpful, would be for those people doing the referrals to get to hear more about the successes that come from those, so that it maintains that hope and it gives them that incentive to keep doing it. And so I think John's suggestion there, like to show like what are not just these quantitative outcomes, but some of the qualitative things that the clients and the other stakeholders have said about that experience.
Well, and you're highlighting, you know, some of the things that we hope we'd be able to deliver that we can't. So, you know, in the other project we're doing in heart failure, there's one particular one around the ED, sort of running an algorithm to divide who's safe to send home from the hospital and who isn't. And the vision in the implementation is to generate quarterly or monthly reports by ED doc and how much they did it. We have yet to be able to access the data on all the patients who showed up in an ED with an opioid use disorder, you know, diagnosis, who didn't get referred. And if we could build those kinds of reports and give real-time feedback to the sites, they will become so much more efficient. And you can add MAT being done in the ED, you know, and all you need, as Holly said, is a D, a U, an A, and we're ready to roll. And it is a challenge. And even with our, you know, Heidi partners, these are our partners, we still haven't been able to get the rest of the data. You know, it's very expensive for every data pull, but Sean, you know, this is advancing your program's work. And so I think that as we are starting to get these insights and the promise starts to become more tangible, we can do it. And then we can work with sort of the remarkable process maps that you guys have built, coupled with the feedback reports that really do that. I think it's going to make a huge difference. It just takes a while.
Is there anything in the chat?
Oh, there's 10 items in there. I have no idea what they.
Question.
They said, John, please be quiet. You're talking too much.
Most of those comments are just for me, you know, like good job, stuff like that.
No, it's great. Well, listen, the next one is
September 19th. Equity and outcomes in maternal health.
fantastic. Well, we hope to see you there. I hope those who can mingle. I know some people have to run off to their next meetings, but you know, really, you should all feel so proud. What a great accomplishment. And really, we're just at the beginning. I mean, I think with this, you know, hopefully we're motivated to keep going and building this out. And Sean, you know, again, for you to get input from you about what is it you need to sell the 14 different hospitals in Springfield, and how can we package this data in a way that really helps, and how can we build the reports to support more referrals at the hospitals in Kansas City and more use of MAT, and I mean, you know, and really quantify this. And, you know, we need to, I think, figure out how do we bundle these reports and create a vehicle for presenting this to the C-suites of the hospitals, to the payers in town, you know, to the Department of Health and others, because I just think, you know, it's got to be appreciated what this EPIC program can offer. And it's, I think, underappreciated and undervalued now. So
one quick thing, and then I'll be quiet. One thing that I'd like to do with this report is feed it to Representative John Black. He chairs the Substance Abuse Prevention Task Force. And last year he asked a question of me that I couldn't answer when we were giving testimony. And that was this. So Sean, what are the rates? What is the differential between those Seans who participate in MAT and those that don't? And I told him, stay tuned. We're mid-step in an evaluation. I was speaking about this one. So we will be giving testimony again, probably in the next couple of weeks. I would love to socialize this with him. And I did not share this, but he tucked in $500,000 this last legislative session. Western Region are getting 2 FTEs, so certified peer specialists, from that fruit. And really, the reason why we got that money, in my opinion, is because one of the wonderful coaches in the Western Region, Ashley Stanley, she basically did the majority of the talking and provided the majority of the testimony. And you could hear a pin drop in that room when she was talking. So anyway, I agree with you wholeheartedly. This type of data is going to yield tremendous fruits, I hope. So we'll just.
Well, and let's pitch to him that he requests some money to support ongoing evaluation and the feedback reports to increase the adoption and referral of patients who could benefit, because, we need it.
Yeah, I agree. Yeah, just thanks again for all your work on this. I'm still processing. I almost cried a couple times during some of the qualitative data, but yeah, I mean, these peers, the workforce, right? They are the model.
Absolutely. All right. Well, thank you, everybody. We'll be in touch soon. See you on September 19th.